Hello, my name is Andrew Kaunitz, and I'd like to welcome all participants, all remote participants, and I see that there's almost 300 of you, which is very gratifying, to this webinar, which will be presented by two experts in the field of contraception and menopause and perimenopause. We'll first be hearing from Dr. Skouby, and then later from Dr. Bitzer. This webinar was supported by an unrestricted educational grant from Besson's Healthcare. Besson's Healthcare had no role in the selection of topics, selection of speakers, and played no role in vetting or reviewing the content of the speakers' presentations, which you're about to hear. So with that, I'd like to introduce first our first speaker, which will be Dr. Sven Skouby. Dr. Skouby is professor in the GYN endocrine unit, Herlev Gentofte University Hospital. He's also in the Faculty of Health and Medical Sciences at the University of Copenhagen in Denmark. Dr. Skouby will be presenting an overview of the perimenopause, including endocrine changes, skeletal health changes, and setting the stage regarding perimenopause. Dr. Skouby.
Thank you, Andy, for this kind introduction to this webinar, which I suppose will be an interesting updated discussion on how to perform the best, the most contemporary counseling in these women. So it's my pleasure to discuss with you how do we optimize when considering the metabolic and bone impact that may be existing with the existing methods, but also be due to the situation, physiological changes in the aging woman. So first, some disclosures. I have, as others, been speaking before, supported by different pharmacies, also acting as member advisory boards in different companies. But as regards the webinar of today, I have no disclosure. So starting out with a kind of medical definition that I'm sure you're all aware with, and that is the definition of perimenopause, but it is in a way setting the scene. So perimenopause is defined as the phase of life inverse of puberty. It starts from onset of symptoms, that is first and foremost menstrual irregularities, and it stops after 1 year when the woman has experienced her last bleeding, and we are coming into the real menopause according to the WHO definition. There's quite a widespread difference between one woman to the other in relation to starting of the symptoms. So the perimenopausal period from a chronological point of view varies between the age of 45 and up to 55, in fact. So how do we optimize contraception during that period? Well, it's always nice to speak about the future. So I will start out by trying to reach the stars. And what do I mean by mentioning that? Well, I think that the future is application of personalized medicine. I'm sure you have all heard this discussion on introducing personalized medicine based upon research advantages made in relation to the decision of one person's full genome. And what has that to do with contraceptive advice in the future? Only that if we take this concept of personalized medicine into the future situation of contraceptive guidance or advice, if we take it into the realm of contraception, a gynecologist or medical specialist armed with extensive information about an individual's health history, family history, lifestyle choices, and possible genotype could conceivably tailor a bespoke paradigm for that particular individual or couple, also in relation to contraceptive advice. So personalized medicine has many definitions. It's often used synonymously with precision medicine, which is defined as classifying a disease or condition based on phenotype findings, such as biomarkers or genomics, and differentiate populations into subpopulations that differ in response to specific treatment. So to translate it into practical medicine, it will enable us to find out which woman will be most suitable for a given contraceptive agent, or which couple will be most suitable for a choice among the different agents available. So we are, as mentioned before, looking at the future. We are at the dawn of personalized contraception in relation to opportunities and challenges with incorporating multi-gene panel testing within the present fertility possibilities and contraceptive possibilities in a given individual or in a given couple. So in the future, and the future is coming close, we will be able to adapt this personalized medicine concept and individualize and optimize the contraceptive counseling. But coming back to our actual situation, at present, how can we adapt to best practice when considering both metabolic and bone health in the perimenopausal period? Well, I think a basic is to understand endocrinology of aging and also comorbidities that may exist or challenge the woman during that period. We also, of course, in detail know or understand the contraceptive needs in the individual woman or couple. And today I will focus much upon the pros and cons of using different hormonal formulations. And by considering these facts or these situations, that will enable us, we will be able to perform individualized counseling according to my best understanding of the clinical situation. So look at some basics before we go to the different possibilities. Let's take a look of the endocrinology of aging, because that gives us some insight also in the clinical possibilities or narrowing in the possibilities that are in general available for women. So if we look at the dynamics as indicated on this slide here, we see that the ovarian reserve, the number of follicles are going steeply down from the age of 35 and down to the age around 50, the menopausal age. I think it's generally well understood that the number of follicles, oocytes that a woman can deal with is given already when she is in the fetal stage. Around week 12 to 16, the number of follicles is the greatest at all that will be reached by the woman also after birth and until menopause. There is a decrease from around 8 million follicles to around 1,000 when the woman reaches the menopause. And especially, as mentioned, during the last 10 years before menopause, we will see this marked decrease in number of follicles, and the number is giving the ovarian reserve. So naturally, this will impact also the fecundity of the woman. And you will see some remarkable endocrinological changes accompanying the decrease in number of follicles. I think also it's today basic medicine that you will have a dramatic increase in the pituitary hormone, the follicular stimulating hormone, which will double or triple when the woman reaches the menopause. And therefore we can also at least theoretically use it as a marker for menopause. And while the number of follicles are descending, you will see that the hormone production will also be impacted with a decrease in estradiol and also progesterone, indicating that the hot flushes will come when estradiol has come under a certain level, and also indicating that the bleedings will be irregular because you have no progesterone formed. The cycles will be anovulatory. So this is, in fact, the dynamics or the background of the endocrinological changes during the perimenopause. And as mentioned, the changes will impact also the chances of becoming pregnant, the monthly fecundity rate. And you will see here that this slide here indicates the fecundity, and it just reflects also the fall in the ovarian reserve as demonstrated on the last slide. So a dramatic decrease in the possibilities of achieving a pregnancy when a woman comes close to 40 and even beyond the age of 40. And this contrasts in a way the situation that is actually taking place in real life these days. Because on this slide here, you see the mean age of women at birth of first child. And this is going back to 2005. And I can tell you in Denmark, we have the mean age of a woman for bearing her first child will come above 30 years of age, as the most recent figures I have seen. So there's a contrast with the fecundity and the decision among women on when they would like to have their first child. It will go beyond the limit for this discussion of today to find out the reasons, but we all know there are social family reasons to consider before the couple or the woman is ready for her first pregnancy. So what are we looking at when we see the situation, the endocrinology of aging and the contraceptive needs? We see that there's a decreasing fecundity, as mentioned, but still women above 35 years constitute approximately 20% of contraceptive users. So there's a great individual overlap between the end of the normal fertile period and the decrease of fecundity during the perimenopausal period. So therefore, the choice of contraceptive methods is affected by the woman's perception of life quality and also earlier contraceptive habits and her endogenous endocrinological situation. We also in real life have to appreciate that there is a change in sex life habits, so coital frequency and ovarian reserve factor interferes highly into the probability of pregnancy. Therefore, methods with lower inherent efficacy may be suitable for some perimenopausal women, and that is again due to the facts as shown at the lower part of the slide, with a decrease in the ovarian reserve and change in the hormonal endocrine situation among sex steroids and pituitary hormones. So in that period, pregnancy may, for some women, be unlikely, in some women unwanted because they have already established their family size. But in other women, pregnancy is still not achieved, and they may to some extent be uncertain on how they should form their life. Is it career? Is it waiting for the right man in her life? Or are there other factors impacting her choice of becoming pregnant? It's a difficult situation for many women. So therefore, you will see that still 48% of all pregnancies in women in their 40s are unplanned, making this the second most common age cohort for unplanned pregnancies. So we as professionals, as doctors that should give counseling, are coming into a special situation in that age group because there are so many personal considerations for the woman to take and for us to consider before giving advice. If we look at the contraceptive use across countries, you will see here if you look at the geographical situation, that there's a great difference, variation between countries. And there's also a change from early on, often sterilization accepted by the female partner, to now using reversible methods such as the pill or the IUD, and the IUD especially after we have had introduced the levonorgestrel releasing system. But all in all, many women are protected if you look at the right-hand side of the slide, but with different methods. And that points to the important factor of giving the optimal guidance or counseling, because there's such a variation based on positions or different geographical areas. So over and above the individual methods recommended, you have to consider what has been established during the last decade, the medical eligibility criteria. And especially when prescribing contraception for women aged over 40 years, health professionals should be guided by these MEC criteria. And I'm sure you know that they are based upon WHO publications or the UK MEC criteria or the US criteria, which are most similar in their content. However, above the general MEC criteria, obviously individual clinical judgment is required, particularly when prescribing for women with multiple medical factors. So focusing a bit on hormonal contraceptives, and again, looking at metabolic effects. What are the pros and cons of using these agencies as contraception? But first and foremost, if you look at the general healthy perimenopausal period, we have quite good evidence from a lot of articles or Cochrane reviews that even in women above 40 years of age, if you prescribe a low dose combined oral contraception, it will only have little and probably no clinical impact in the situation, the metabolic situation leading up to any situation with a disease situation. We know that from, for instance, this study here, where there was a group of women, 50 women, using the combined compound preparation and using IUD. And on the slide here is giving, in the upper part of the slide, the fasting glucose and the glucose tolerance test over a 3 hours period. And you can see here that in these women who were healthy, there was no difference in the oral glucose tolerance test in the control cycle and after 6 months intake. In contrast, there was a difference in the IUD group, which cannot be just simply explained. But the important thing is that looking at glucose metabolism, there seems to be no impact from a low dose combined product. And if you look at lipid levels here, cholesterol and triglycerides, you can also see in the upper part of the slide that low dose combined contraception with hormones seems to have no impact. In this study here was used a combination of estradiol and levonorgestrel. You might find small changes in newer products if you compare with levonorgestrel if you use newer products with third and fourth generation, the expression should be avoided, but the newer types of progestins, such as drospirenone or desogestrel, you will, or noclismet, you will see here that that there is minor changes, but all in all, there's no clinical effect using neither of these low-dose products on lipid metabolism. In the IUD group, not a surprise, no changes in lipid levels. So going back to the different low-dose preparations available, here we can use whatever is supporting compliance, whatever product that the woman feels is suitable for her without perceived or real side effects. And the metabolic situation is given here on this slide here. Only minor biochemical changes was associated with the low-dose product in that situation, levonorgestrel, but it's the same with other products containing newer progestins, only minimal changes with no clinical significance. So the low-dose combined contraceptives can be a satisfactory contraceptive choice for all healthy perimenopausal women according to their perception of side effects, and therefore supporting or not supporting a good compliance. But evidently, when you come to the age of 45 up to 50, there may be coexisting comorbidity, which can include the situation given here on this slide here. And here we have to consider if there's any deterioration of the condition or impact on medicine given against the conditions when prescribing OCs or the combined OCs. And especially when this is the situation, you need to again consider or consult the MEC, the MEC criteria, because they are set up in order to underscore recommendations on safety of methods for people with certain health conditions. And I'm sure you have seen the table on the lower part before. The MEC criteria is dealing with 4 categories. The category 1 is a method that can be used in all circumstances, and in also in situation if there is at least limited clinical judgment during use. And category 4, the method should not be used. So this is the MEC criteria, a very practical tool in order to secure that the guidance, the counseling you give is according with results of best research dealing with the different comorbidities that may exist. So in my last part of the presentation here, I will give you some information on BMD, bone mineral density, what are the pros and cons of hormonal contraceptives again. And I will just turn your attention to one large study, a systematic review published back in 2006. And just to make it short, it included 75 articles on the effect of combined OCs on bone density in the premenopausal and perimenopausal populations. And the evidence was appraised by the Oxford Center for Evidence-Based Medicine with the different levels of evidence you may know. And the conclusion is that there is good evidence for a positive effect of all contraceptives on bone density in the perimenopausal women, and a fairly good evidence for a positive effect, meaning prevention on fracture when women have been on the OCs for more than 5 years in the perimenopausal period. It will prevent fractures in the postmenopausal period. So this is contemporary conclusion on the combined OCs in relation to PMD, and quite reassuring for our clinical guidance or recommendations. So as conclusion, at present, how can we adapt to the best contraceptive practice when we are considering especially what we have been discussing here, the metabolic and bone impact that could be that could be causally related to comorbidities. When we do that, we have to include understanding of the endocrinology of aging, taking that into consideration as discussed. We need to consider the contraceptive needs that may vary quite a lot during the perimenopausal period for reasons as mentioned before. And we have to evaluate pros and cons of different hormonal formulations when we discuss this preparation or these preparations, which are still the most preferred among perimenopausal population, despite an increasing use of also the IUDs or the LNS. But again, at the bottom, the most important message is to perform the individualized counseling, taking these items into consideration, because that will, needless to say, increase compliance. And this is, of course, what is highly needed when you look at still the high number of unwanted pregnancies we can find in the perimenopausal population. Thank you for your attention.
I'd like to thank Professor Skouby for that excellent overview about perimenopause and contraceptive implications. And I'd also like to remind our audience, which is now greater than 560 participants, which is a very wonderful number to see, that the Q&A button at the bottom of your screen can be used and should be used to ask questions. And then after both presentations, we'll be addressing the questions with both speakers. At this time, it's my pleasure to introduce our second and final speaker, Professor Johannes Bitzer. He's Professor Emeritus and ex-chairman of the Department of Obstetrics and Gynecology at University Hospital Basel and director of the Basel Institute for Sexual Medicine and Sexual Therapy. Dr. Bitzer will be continuing on the same theme introduced by Dr. Skouby, and we'll be getting more specifically and more clinically and practically into contraceptive decision-making for clinicians and their perimenopausal or older reproductive age patients. Professor Bitzer?
Thank you very much, dear Andrew, for your introduction. And thanks a lot to Sven for giving me the real scientific background of my talk. I will try to put this scientific knowledge into the practical consultation in the contraceptive counseling, and include also some of the non-medical and psychosocial aspects. If you look at the premenopause, there are these biomedical characteristics, which Sven has already described: the decline in fertility, ovarian aging. From the reproductive side, it's an increase in miscarriage, chromosomal abnormalities, pregnancy complications. There is a progesterone decline and estrogen fluctuation with irregular and heavy bleeding, climacteric symptoms, bone demineralization. There is an aging-related risk increase for cardiovascular diseases and a risk increase for gynecologic neoplasias. On the psychosocial side, these women frequently are in an ambivalence regarding family planning. Should they remain childless? Should they have a late child? Do they have enough children? Their psychosocial situation is frequently characterized by having sort of this sandwich situation. There are the adolescent children, there is the care for parents, there are the professional career challenges at a maximum frequently in this phase of the life, and at the same time maybe a decline in energy, burnout and depression, and loss of sexual desire. So these are, sort of the main issues we are confronted with: the age-related increase in high-risk pregnancy and fetal abnormality, the age-related increase in cardiovascular diseases, the cancers, the osteoporosis, and the negative impact on the quality of life of these women, typically the iron deficiency in the context of heavy menstrual bleeding, climacteric symptoms, depression, sexual dysfunction. We can go through very briefly just to mention the main clinical facts: cardiovascular risk and age increase. It's really in the perimenopause that the risk increases. It is also the absolute risk increase in VTE, as you all know, the background risk increase, and so we have a rather, almost a little bit threatening situation regarding cardiovascular health. You can see that also the issue of stroke becomes, although it's rare, but it becomes something of concern. The cancers, as you all know, all increase with age except for the cervical cancer, but ovarian cancer increases, breast cancer cases in women aged 50 or older, about 80%, endometrial cancer, primarily disease of old age. So this is the oncological view. Regarding quality of life and sexual health, these are the famous studies, older studies, but they have been repeated in different populations, that the perimenopause is really a phase in which changes occur in sexual health, in sexual responsivity, sexual frequency, sexual desire, vaginal dyspareunia increasing, and partner problems increasing. It has already been mentioned that it is a threat to the bone mineral health in perimenopausal women regarding bone mineral density. You all know that up to 25% of perimenopausal women present hot flushes and sweats. You also know that this is a life phase in which a considerable number of women suffers from heavy menstrual bleeding, leading to iron deficiency or even iron anemia, and that this is also a frequent reason for consultation in the in the office of the gynecologist. From the mental health side, it is notable that this seems also to be a transition period in which affective disorders increase, where you can see that in a follow-up of patients by the Suarez and Cohen group, you could see that there is a considerable increase during the phase of perimenopause. And this increase is even more intensive when the vasomotor symptoms are present. So what is actually then our task in contraceptive counseling, as Sven already mentioned? So which are the preventive and health promoting challenges of contraception? So we have, on one hand, we should not increase or even protect against the age-related increase in cardiovascular disease, cancers, osteoporosis. Look that we do not increase the risk, or if we have any sort of preventive approach. That, of course, we should prevent high-risk pregnancy by the efficacy of the method. And if possible, not aggravate or alleviate, or on the other side, better alleviate the perimenopause-related negative impact on the quality of life, which is heavy menstrual bleeding, iron deficiency, climateric symptoms, depression, sexual dysfunction, and stress-related dysfunctions. So you may already know that we have tried in Basel to develop some sort of a structured approach in contraceptive counseling, also in the different phases of life, that we believe the art of counseling is to bring three variables together: the woman's profile, the context, and the method profile. Because in fact, we do have a lot of methods available. And for each of these methods, what we as physicians have to know based on evidence-based medicine and studies is what is the efficacy of the method, what is the effectiveness of the method, what are the health risks, what are the side effects, and what about the health protection and the benefit. So you can see this is already a huge amount of available options, and for each options we somehow have these four main characteristics to look into. This is variable one, the method profile. The variable two, the woman, we all know about that. This is very important, medical profile, because this is the basis for the medical eligibility criteria. But what is frequently a little bit overlooked is that there is this sort of subjective values and objectives, the family planning values, the health beliefs, the concerns and fears, which are not the medical profile, but it is more the psychological or the subjective profile. And then we have the psychosocial profile, which are the behavioral risks, which are the stresses, what about the pre-existing mental and sexual health situation, and what are the psychological symptoms. And finally, in our consultations in the different countries, of course, we have the socioeconomic environment, which puts, the interaction of the woman in the method into a certain context, the socioeconomic environment, the culture with the values, and the available health system. Is there accessibility to all methods, and is there accessibility to good counseling? Like, as I mentioned before, the health beliefs, the sexual right, the accessibility of services, etc. Now, if we go into the methods, I would just sort of, on a very practical basis, look into the pros and cons of the big five: the copper IUD, the LNG, the Implanon, the combined hormonal contraceptives, and the DMPA and progesterone-only pill. As Sven already mentioned, there is no contraindication for any of these methods by age only. At each age phase, all these methods can be used. If you look at the copper IUD, and this is now sort of a clinical overview, you can say there is no cardiovascular risk on an evidence-based level 1, there is no cancer risk evidence-based level 1, there are rare complications which are mainly the use, the application itself, and of course, this method needs a healthcare professional for insertion and removal. There is hypermenorrhea, dysmenorrhea, lower abdominal pain with a low frequency, and then you have the protection against endometrial carcinoma, and there is also indication that there is protection against cervical carcinoma. What about the NLG IUD? Again, you need a health professional. It's not under the control of the woman. There are rare complications in the context of the use. You have no cardiovascular risk, breast cancer risk conflicting, none or low. It disappears certainly after 10 years. You know all about these studies that come to controversial results, but one of the important studies is that there is no long-term negative impact on breast cancer risk, in the sense that women after menopause who use it before have a higher risk. There is bleeding irregularity, amenorrhea. We know about that. Amenorrhea can be an advantage. The big issue in at least my country was that there were these reports from Denmark about depression and even suicide. There is a lot of controversy about this, and I think the evidence is not clear, but we have to take it, of course, seriously when a patient reports that there is this intolerability towards even a low dose androgenic progesterone. You have again these protections, also in the context of tamoxifen or mitral hyperplasia, and of course it's an admitted therapy. I'm sorry, it doesn't come in my slide for heavy menstrual bleeding, as you all know. Now, sorry. I'm sorry. Okay, not for one. What about Implanon? It's again the issue of the LARCs, which need a professional person, and which needs a professional not only for insertion but also for removal. And the main complications actually are in this context. And again, you have a rather positive health profile regarding age-related risks. You have regular bleeding. There are some reports on negative mood, typical progestogen effect in a medium dosage of progestogens. Some people report about skin changes or weight. The benefits are reducing dysmenorrhea, also maybe in endometriosis patients, reducing ovulatory pain, reducing menstrual migraine. There are no studies about cancer protection or cancer increase, really. What about the progestogen-only pill? You all know it is, from a health point of view, risk point of view, very low. Again, typical progestogen-related effects, but it is a low-dose application of progestogen. Bleeding irregularities, we are now learning from, as you all know, there are 2 progestogen-only pills now on the market or coming on the market, which try to, the second one also tries to improve the predictability of bleeding. The typical issues are the same regarding the benefits. Depo-Provera, I think we could still say that the cardiovascular risk profile is favorable, although there are continuously ongoing questions whether there is not a very slight increase, because it's actually a high progestogen dosage contraception. And in this context also, there are some studies indicating that there may be some small increased VT risk. But as you all know, the main issue is about bone health. But we know, and especially Andrew has shown us very nicely, that it's not worsened by menopause, and there is a recovery. It is accompanied usually by amenorrhea, which may be something which we want. There is some studies indicating weight gain, and one of the issues, of course, is longer duration to regain full fertility. Issues of protection are ongoing, and it's not quite clear, but it may well be that this endometrial and ovarian cancer protection may also be available. And then finally, we have the combined hormonal contraceptives. Here we know a lot. I mean, millions of women have used it. We are quite sure what we have on the risk side. VTE risk, breast cancer, which disappears after 5 years, stopping 5 years after use. Cervical cancer 1.2. And we all know, we have discussed this frequently, that the absolute risk is low. And that also, putting it in relation to pregnancy, it has still a sort of a favorable profile. You all know from the huge list of possible side effects. Interesting enough, and I remember that in the very early days of the pill, there were studies doing really having a comparative design, and they found in the placebo group quite a similar profile of side effects. So the question is always, is this really pill-induced side effect? But anyway, we know about it, and we have to take care of it. What is interesting about combined hormonal contraceptives, and Sven has already pointed to it, it's a huge list of possible benefits. Protection against cancer, ovarian, endometrium, colorectal, and you know that ovarian endometrium cancer protection is for a very long time, maintaining it on a long-term basis, osteoporosis prevention, climatic symptoms, reduction of menstrual bleeding, reduction of hyperandrogenic skin symptoms in patients, mood improvement, which has been shown by the psychiatrists, improvement of sexual function, which has also, there are some controversial results what the estrogen does, but in general, there are quite a number of studies showing that there is an improvement in sexual function. So how to put that in a sort of a practical model? I think we have these sort of two variables here. We have the woman, and here we have the method. And now how to find the best method for the individual woman. If we first look at the subjective part of the woman, which is usually called now in the literature needs, values, beliefs, we have the expectations, what should happen with my menstruation, what do I want daily, non-daily, the fear of cancer, fear of losing fertility. You have the beliefs, the values, and listening to women, we can already maybe exclude or at least put in a second row methods which were mentioned as not fitting into the individual needs profile of the woman. We can put it like exclude methods which a woman does not want or do not meet her needs and values. And that may already reduce the options here on this side. Now the next step is looking into the medical and psychosocial profile of the woman to see whether among the methods which are still available, which correspond to the needs, whether there are any methods the woman should not use for medical reasons or even for psychosocial reasons, using the medical eligibility criteria as Sven has very nicely shown. Regarding the psychosocial profile, we do not have a correspondent international document in the sense of eligibility. So this is more something based on the clinical experience people have about what you would give for example, you wouldn't give in a postpartum period with a postpartum depression, you certainly would not give Depo-Provera, etc. So you have, these are the two sort of exclusion steps which limit your choices. Here, again, the combined hormonal contraceptive list. We have a lot of help also from the UK, looking into what are the exclusion criteria for progesterone-based contraception, short and long-term differences. And then finally, the last step would be that among those methods which are eligible, are there any methods which would give an additional benefit? And that's something Sven already mentioned also, that regarding the continuation rate, regarding the acceptability, it is quite important if there is any additional benefit for the patient. And that's based on our knowledge of estrogen dosage, type of progesterone, long-acting, short-acting, etc., corresponding to possible additional benefits from the different methods. And Having done these steps, then sort of the last step is what we call the shared decision making. Shared means there is the physician and there is the woman. And you can say the physician's role is to provide evidence-based information about benefits and, for example, of course, the benefit of effective protection against unwanted pregnancy, additional benefits, life phase-related perimenopause, and the risks on the other side, all the evidence-based information which we have, which the woman has to know as in informed consent, meaning that we should be able to explain it. And then the woman's role, which gives weight to these, which gives the individual weight to this information. Is this important for me? Is this less important for me? What are my priorities? What are my concerns? To allow questions. So finally, to take some take-home messages, perimenopausal women have a naturally low fertility rate, but still need effective contraception to protect them against unwanted high-risk pregnancies. The transition period carries with it age and endocrine-related changes, which have an important impact on the general reproductive health of the woman, as well as her quality of life. Each contraceptive method has 4 basic characteristics with special relation to the perimenopause: efficacy, health risk, tolerability, additional benefits. Each perimenopausal woman has her individual biopsychosocial profile consisting of her objectives, her medical risks and resources, and her psychosocial profile. So good contraceptive counseling and care aims to make the best fit between contraceptive method and individual woman by structured interactive counseling based on principle of patient-centered communication and shared decision-making. Thank you very much for your attention.
Thank you, Professor Bitzer, for a very useful and comprehensive overview of contraceptive decision-making for our older reproductive age patients. So I'm happy to see that a good number of you have used the Q&A button at the bottom of your screen. I have been aggregating the questions, and in a moment I will give both Professor Bitzer and as well as Professor Skouby an opportunity to answer. I'm going to request, so that we have time to do as many questions as possible, I'm going to request that the responses be brief and to the point. A common theme among many asking questions out in the audience, which is more than 560 now, was the impact that both combination hormonal contraceptives as well as the progestin IUD have on future risk of breast cancer. So perhaps both of you could weigh in there, and perhaps Dr. Skouby can start, since much controversy has been injected into this area by a Danish investigator.
That's right. We have in Denmark exceptionally good registers, and much of the information on this issue here has come from these registers, indicating a small but increased risk of breast cancer after long-term use of OCs and disappearing again after 5 years. But I know that Finnish data in Finland, they have also good registers. They are coming up with information that contradicts this idea of increased risk.
Thank you. Professor Bitzer?
Yeah, I think it's especially in Switzerland, the LNG IUD discussion regarding breast cancer risk was quite sort of public. And as Sven already mentioned, I think there are really controversial results, and I respect very much the big database of Denmark. But as we know, cancer, the physiology or the development of cancer is a complicated process, having a lot of variables coming into play, including also diagnosis, including access to diagnosis, etc. So my concern is that the statistical differences, which, if you look at it from an epidemiological point of view, are below 2, relative risk increase below 2, that would, I think, put some doubt whether it's really clinically of such importance, and whether it is really helpful that these anxieties are created.
Yeah, thank you both. So this is a question that my older reproductive age patients frequently ask as well. And yes, we have the Danish study, but we also have very large long-term British cohort studies showing no elevation in risk of breast cancer with combination oral contraceptives. And there were earlier European studies, particularly Scandinavian studies, not showing an elevated risk. So how I counsel my patients is that if there is any elevated risk, it would be very small. And it's also possible that there's no elevated risk whatsoever, because as we, the three of us know, we are not seeing and are not likely to see in the future randomized trials following women randomized to different contraceptives over several decades until they are or are not diagnosed with breast cancer. I don't think we'll ever have a study like that. So we are left with observational data, which is imperfect. And thank you both for your responses. So another common question from a number of participants relates to when to stop hormonal contraception in our older reproductive age or perimenopausal patients. And furthermore, is testing for FSH or other biomarkers useful in this clinical context? Let's start with Dr. Skouby.
I mean, this question pops up from time to time, and early on there was a statement made on at least one of the bigger congresses that if you measure FSH during a pill-free interval of 7 days, you could have an indication of whether the woman had reached menopausal situation. And if you waited 2 weeks, even better information on that situation. But I think today, in most European countries, I suppose also in the US, you do not lean on biochemistry in order to find out when it's the time to stop. Also because the woman above the age of 50, up to 55 maybe, and who is healthy can use COC.
Okay, thank you. And Professor Bitzer?
Yeah, well, I think it's the same. We still have in Switzerland some practice that after stopping the pill and asking the woman to protect via condom or abstinence, make an FSH, and about 6 weeks later make another FSH, and if both values are high, that you may then consider that fertility is extremely unlikely. But in practice, I would agree that it is a safer procedure to go for what is said to go for age and a very low likelihood. What certainly is not helpful is just one FSH, and if that is high, say, okay, you are free.
Safe side.
So thank you both. The US medical eligibility criteria, which both speakers have referred to, as well as WHO criteria, are available in an app. Let's see if I can, here's a little bit what the app might look like. And it is a free app. And if you go to your Apple or Android app stores and put in CDC space contraception, I think you can get access to this very easy to use app. And the CDC guidance would suggest that if women continue to be medically eligible, to use contraception from a safety perspective. That is, there are no cardiovascular risks that would prevent safe ongoing use of estrogen progestin contraceptives. They can continue until age 55, at which time contraception can be arbitrarily stopped without concerns that the patient still needs contraception. Okay, so thank you for those responses. Here's a question I got from several participants. In our perimenopausal patients, should we use oral contraceptives formulated with lower estrogen doses? So in other words, should we vary which dose of contraception we use based on age of our patient? And I'll ask Dr. Bitzer to comment first.
So the question was whether we should go for the very low estrogen dosage related to age, like around 40. Yeah.
Right.
Well, I think in my view, it is useful to go for estradiol preparation, actually, which I think the studies seem to indicate that this is the lowest, somehow the lowest estrogen exposure. So yeah, usually you could go for the lowest ethinylestradiol dosage, but I would rather think of going to an estradiol dosage because in the 45-year-old woman or so, this may even be continued to 55 and at the same time treat climacteric symptoms.
So just so I'm clear and the audience is clear, so although we may not have comparative data, you're recommending that clinicians consider using estradiol as opposed to ethinyl estradiol oral contraceptives in older age group women because it may be safer from a venous thromboembolism risk as one consideration. Would you include the new E4 or estetrol oral contraceptive formulation along with estradiol pills?
Yeah, that's a good point. I mean, all the laboratory data seem to indicate that estetrol is really, from a cardiovascular point of view, very safe. And I would, of course, there are good indications to do that, but of course there are studies needed. But from the background information, that's an interesting issue. I think ethinylestradiol will disappear after a while.
Okay, and is the E4 or estetrol oral contraceptive formulation available in Europe?
It will be soon, yeah.
Okay, it is available in the US just recently. It sounds like it's coming your way soon. Dr. Skouby, anything to add about estrogen dose in our perimenopausal patients?
Well, I agree with Johannes in choosing the genuine estrogen, estradiol. There are some pharmacokinetic differences between the artificial and the genuine one. But if you look at risk markers, there's less impact from the genuine. But again, here you have an option also between the combined oral contraceptives and maybe using a low dose, so to say, LNG, and combine it with, for instance, a patch with estradiol.
Thank you for that. So a little bit more specific question came from one participant about use of combination estrogen progestin contraceptives in women age 40 who have migraines without aura, and would that be appropriate or not? Dr. Bitzer, could you respond?
Well, if I'm correct, the European Society of Headache has published something about it, and there was more the recommendation that especially in these cases where the migraine may be related to menstruation, that the recommendation would be to give progestogen only pill in a continuous way.
Okay, and Dr. Skouby, any thoughts about migraines without aura in our perimenopausal patients? What contraceptives would or would not be appropriate?
I mean, there have been never any reports on progestin-only contraception and complications such as cerebral thrombosis in women with the migraine. But on the other hand, if a good bleeding control is extremely important, I would consider a low dose without the pill-free intervals, so you don't have oscillations of the hormones.
Yeah.
Okay, I thank you both. I think it's important to recognize that there's a lot of confusion among many clinicians about what is an aura. Menstrual migraines, which our experts have referred to, are not considered migraine with aura. These are migraines which tend to be precipitated only in the premenstrual or luteal phase and then resolve with the onset of menstruation. That's different than migraine with aura. And also common symptoms like photophobia or scotomata are also not considered migraine with aura. And different national headache societies have definitions about what aura is. And it's usually visual, but sometimes can be oral or other sensory manifestations. I looked in the US MEC using my app, and it indicated that in older reproductive age women who have migraines without aura, that was considered category 2. So it was still a green light to use combination methods, but it was not category 1. For all of the non-estrogen methods, it was green light category 1. All right, so we had a question from a different participant. Can a 46-year-old healthy woman use combination contraceptives strictly for menstrual management? This is a woman who perhaps has had a tubal sterilization or no partner, doesn't need contraception. Would it be okay to use combination contraceptives for menstrual management? Professor Bitzer?
Well, that's an interesting question. And I'm not quite sure. To be honest, I would have to consider the different pros and cons and look, if possible, for other methods to, for example, if it would be that there is irregular heavy bleeding, that you might use a progestin or progesterone in the second half of the cycle, starting at day 12, and thus having some sort of regulation. Or you would give a menopausal hormone therapy.
Okay,
Mm-hmm.
thank you. Professor Skouby?
Yes, again, to make it short, I'm quite in agreement. Of course, it's a nuisance for a woman who has been sterilized, as you suggest, to take up, again, hormonal contraception. But from a safety point of view, she could do it, but better maybe with sequential progestin, or maybe, again, with an LNS insertion.
Okay. Keep in mind, and this question pushes us a little away from contraception into gynecologic practice. But if you're seeing a woman in her mid or late 40s with abnormal uterine bleeding, she needs to be evaluated prior to starting her on therapy. Right. And evaluation, it would depend on what type of clinical background you have and what access you have. But endometrial biopsy may be appropriate, and also an ultrasound, either a plain unenhanced vaginal ultrasound or a saline infusion ultrasound, or in some practice settings, even office hysteroscopy might be appropriate. So those evaluations might be first, and then if the patient's a good candidate, medical eligibility 1 or 2 category, and you've ruled out endometrial pathology, then I think you could start combination methods. All right. So what about the safety of combination methods. One participant asked, when treating a woman with polycystic ovarian syndrome, who's also in her 40s, not a young woman with PCOS, but an older reproductive age woman with PCOS, is it safe to use combination hormonal contraceptives? Let's start with Professor Bitzer.
Well, that's a good point, and that's a difficult issue. I think the argument would be that, first of all, at that age group, you have an increased risk for VTA age-related, so the background risk is increased. You have an increased background risk regarding PCO situation. So in that situation where the background risk is regarding absolute numbers increased, the 1.3 increase in VTE risk has to be considered as more relevant than in a young woman. And I would rather look into other solutions for this lady.
Okay, I think you make some very good points. Professor Skouby?
Yeah, it's an interesting question, of course, but let's consider the PCOS situation, because it seems that the bleeding disturbances level off according to increased age. So the bleeding situation may be better in the PCOS women with an advanced age compared to younger PCOS women. The other thing is weight. 60% of PCOS women appear to be overweight. And here the VTE problem is, of course, obvious. We do not know so much about the PCOS condition per se in relation to VTE. There are 2 good American studies, including 4,000 women in each, and they come to different results in relation to impact from COCs in PCOS women. So the jury is still out. But in principle, I think you can use the combined COC in PCOS women also in that age group.
I think all 3 of us agree, and I think we can send a unified message to our over 450 current participants that if your patient is older, and which is our focus today, and your patient also has a high body mass index of 30 or greater, as many women with PCOS have, as Professor Skouby has pointed out, then you start getting into the medical eligibility criteria of multiple cardiovascular risk factors. And then that's when the categories go from 2 to 3 in terms of risk. And so I think all 3 of us would agree that if your PCOS patient is in her 40s and is also obese, which we see more of in the US than perhaps in other parts of the world, it would be indeed better to avoid a combination method and instead focus on progestin-only methods, including progestin-releasing IUDs.
Especially because of hyperplasia and cancer, is the risk is increased in the PCOS population.
And maybe one of the new oral progestins, which have some sort of a little bit of anti-androgenic property.
So here's a question about should you continue combination hormonal methods in a perimenopausal patient who has recently had to start taking an antihypertensive medication to control recently diagnosed essential hypertension? Professor Bitzer?
Yeah, I think if the hypertension is controlled, the eligibility criteria, I think, are quite clear about this. That it would not be a category 3 or 4. Maybe I'm wrong. Sven, what do you think?
I'll check, and perhaps while I'm checking, we can get an opinion also from Professor Skouby.
Yeah, I think that the medication, the control of the blood pressure is essential here. And I mean, there are some women who have a hormone-dependent blood pressure. So in all cases, check the blood pressure after starting both the COC and even HT in the menopausal woman. But in both situations, I think it's acceptable if you start out with a well-monitored and well-controlled blood pressure.
Okay, so here, under condition on the app, I put in hypertension, and this is adequately controlled hypertension. And you can see a lot of green, except at the bottom, it becomes reddish pink. And the reddish pink is for combination methods. So, so for all methods except for estrogen containing methods, it's 1 or 2. And then for even well-controlled hypertension, at any age, it's actually 3 for combination methods. So let's go back for a second now.
But that's
what
US.
about,
That's US.
yeah, yes, that is
I'm not
US.
sure whether the other,
Yeah,
the
so-
WHO has the same.
Exactly. Yeah, good point, Johannes, because the WHO might be less rigid or strict. And it is true that we have more malpractice attorneys in the US than you have in Switzerland or Denmark. And that is a real issue. Okay. Let me, I'm going to have one more question because it's time to close soon. All right. So this will sort of reinforce what we've already discussed, but this will be our closing question. What is the ideal time to remove a progestin IUD in a woman who's in her late 40s or early 50s who does not report vasomotor symptoms? She's free of bothersome hot flashes. She's been doing well with her progestin IUD, and she's now 49 or 50, we'll say. Would you just leave it for a while or remove it? We're going to ask Professor Skouby first, and then Dr. Bitzer, and then we will be closing shortly.
I think here, as in other matters related to the perimenopausal woman, you need a personal consultation and need her opinion on the situation. You will run no risk of continuing with the IUD, although the risk for her to become pregnant is maybe eliminated. But you know, hot flushes can appear after some time, and if you leave the IUD, you can just add some transdermal or small estrogen dose.
Right. Yeah,
Exactly.
I have used the term surfing through perimenopause to describe continuing the progestin IUD and adding transdermal estrogen. Professor Bitzer?
Well, that was an easy one.
All right. So anything to add? We do have one last slide, and I'd like all 446 participants to wait for this last slide. Anything to add, Johannes, before this last slide?
Well, I think I like the meeting. Although we couldn't sort of prepare it. I think everybody was working on his own, and yeah, I think maybe because we have a certain age, I liked it really.
I will also point out that the Q&A includes many complimentary comments, including comments like wonderful discussion. And I know I always look forward to the clinical discussion from the experts, and I appreciate all the questions, and I particularly appreciate the expert answers from our two professors. So I think it's time now for the last slide. So it is our hope, it is the IMS hope, that next year in 2022, that all of us will be able to have a live IMS meeting in Lisbon in late October, as you see. I'm thinking I would love to go. I have actually never directly participated in an IMS meeting before today. And I've been very impressed by the program, by the quality of the experts, and the excellent questions submitted by our learned audience. So perhaps I'll see Johannes and Sven and meet many of the folks who asked questions next October. Let's hope the pandemic's better and that we can travel on a live basis to next year's IMS. So thank you, Professor Skouby. Thank you, Professor Bitzer. This was a very educational and a really a wonderful webinar.
A pleasure.
Thank you. Bye-bye.
Bye.